Yeah. And I don't know, the CTA FFR is pretty expensive. And that's why the problem is that we started and then it's not getting reimbursed. But we are ending up with the IFR in the lab. So Sanjay mentioned about the who are the patients and what kind of lesions we'll call it as a cheap case. I'm not going to go into that. So the patient comorbidities are important, the complexity of the lesion, and then one of the important thing I would mention is the operator experience. It is very important, and the hemodynamic compromise. Two things, hemodynamic compromise and anticipate that the hemodynamics may get worse. So this is a case, 66-year-old female. She was admitted in cardiology with the non-STEMI, and look at the comorbidities, the diabetes, hypertension, CKD, and EF 30 to 35%. And then left heart cath showed this. The ostial LAD. Then there is proximal LAD, and I don't know how much you can appreciate. There is a lot of calcification also. And then the right is occluded. So question is, what do we do in this patient? And we did the CVT evaluation, and they are saying this is high risk for coronary artery bypass surgery. So should we continue with the medical therapy and bail out? So we are trying to pull out the data on the, and Dr. Guzman is probably going to mention in the next talk, about the LV dysfunction and then the multivessel revascularization, complete revascularization, the REVIVE trial. But in the acute coronary syndrome, I think there is still a role for revascularization. We, nevertheless, in this patient did the viability scan, and you can see lots of viability, particularly if you look at in the LAD territory. So we now wanted to see that how we can prepare this patient for a best PCI outcome. So we need to do a few things. The imaging before and then after, and then make sure there is no complication from the procedure. These are the very simple rules. We need to assess the plaque composition, and then the length and the diameter, and then confirm the landing zone. We can calculate the MSA, the stented segment area, and make sure that we assess. And I usually say sometimes we get questions about how about if we don't have imaging? I think still it is important that we monitor the patient clinically, EKG-wise. These are basics in the cath lab, angiographically, whether there is any dissection. These are still valid, and we should be watchful for this. And what we are looking for, yesterday we had this question that can we do a direct stent or do we need to prepare? And once we have the imaging, and angiography may not be the best in terms of understanding the calcification, we need to have intravascular imaging, but what we are really looking for is the MLD. Morphology, length, and diameter. And the post-PCI, we need to look at MAX, max. That means the medical dissection or not, apposition, and stent expansion. So not all dissections need to be treated with another stent, but we need to be making sure there is no compromise in flow, as dissection is not coming back and haunt us. And then question about expansion is very important, and we'll do everything to do the expansion. But I will leave that apposition part later for the faculty to decide, because how much apposition we need? Or do we need to be crazy? And if that is the case, every procedure we do, we also need to look at the cost and the resources. And I tell you another important thing. When we do the complex case, we also tell the team in the cath lab that this is so-called chip case and be watchful. You may forget to do small things like monitoring the ACT. And by the time you are done and you are doing the IVAS post, the ACT may have dropped, and then you may end up in a thrombotic complications. That has happened. And I don't need to tell this audience that imaging is better. In the ultimate trial, that's conclusively showing, I think there is no need to fight on that. But the question remains, how we prepare and can we follow a simple algorithm after assessing the lesion? And you will hear later that if the wire goes and the balloon does not go, then all bets off. Then we'll have to make a different strategy. But if the balloon goes, then we can try to see whether balloon is optimally inflated. If not, then we'll have to escalate. And one of the ways to make sure that we get a good balloon inflation, it's a simple rule. If balloon does not inflate well, stent is not. So sometimes we say, okay, we'll do the stent, and then we try to, if it is in the mid segment, we can do post-dilate. You may hope for it, and many times you may be able to get away with it, but sometimes you may not be able to get away with it. So it is better to prepare the vessel right. And we have other tools when simple non-compliant balloon or a score balloon, or now we have the excellent tool, if the balloon crosses, you can use the lithotripsy shockwave balloon. And if the balloon does not cross, you can also do the dog boning, like so what I call the, not dog boning, the wood pecking. So you can push the balloon and then give the shockwave and then advance and then do shockwave. But in a long lesion, I think it may not be that good in terms of getting the optimal preparation. So in this case, what we did, we did the patient's LVEF is bad and EDP was high, so we did some mechanical support. As you know that in the cath lab, we actually make things worse to ultimately get things better. So that transition, when we are working on the coronaries, when we are making things worse, we should have some kind of supportive mechanism. And I told you yesterday that once the impella is in and the cardiac output is good, we just very at ease, we are doing the procedure and no issues. But there are a few things you need to remember. Why we need to know the CKD patient, creatinine, we need to be very careful about the use of contrast amount. So a lot of things are in play while we are doing this kind of complex high-risk patients. See, in any case, with the shockwave, we did okay, and then we did the imaging, and then the, as anticipated, the circ may get worse. We did IVAS, and then bail out, and then come out good with the left main intervention as well. 85-year-old, hypertension, hyperlipidemia, CTA showed extensive calcification in the distal left main and proximal LAD. But when we did this, the left main lumen area was not bad, but the LAD looks like worse. So we thought that we prepped this. We did the IFR because this patient did not have any stress testing. And this is the IFR before, then IVAS, and then we did the balloon preparation. I did not even try the non-compliant balloon. I used the IVL, and then we did the stent, and then IFR 0.96. In this case, we did actually IVAS, but my question to you, can we get away with an increase in IFR from 0.78 to 0.96? Is it good enough? And I think that sometimes is very helpful because that may reduce the cost on the patient. So the plaque modification is important. And we have several tools now on plaque modification. We're happy that the shockwave is here, but it may not work for all the lesions. And Disrupt 1, Disrupt 2, the procedural success was very encouraging. But the problem is here that, compared to rotational atherectomy and orbital atherectomy or shockwave, if the balloon does not cross, then we cannot use it. So we need to understand the different limitations for different tools. And it is important that we use it properly. And we can use it in combination also. We can use the rotational atherectomy, and still there is residual. Then we see a long balloon, long lesion. If there is a small segment in the long balloon that is not giving in, then we can use the shockwave at that area, and then we can bring the stent and get the optimal placement of the stent. So, optimal PCI in chip case. I'm not going into details about what we will accept as the optimal PCI. Of course, that has a long-term implication in terms of outcome, but we need to understand that a complex patient, a complex lesion, we need to be very vigilant and prepared. It may be a planned PCI or it may be an ad hoc PCI, but we need to have that concept that these patients are different than our usual garden variety PCIs. And whenever it is needed to modify the plaque, we should assess the lesion, the morphology, the length, and the diameter. And following the intervention, we need to come out good, assuring ourselves that stent expansion is good, stent apposition is good, and there is no residual dissection that needs to be treated. My question to the faculty is that if the left main distal bifurcation, which is, I would not call it side branch or main branch, but where probably the imaging is still very much warranted, in other cases, can we get away with the physiology alone? That needs to be questioned. And we'll have to wait for trials to see what we get in future. Thank you.
Thank you, Dr. Ahsan.